All right, welcome everybody to our first session today for putting the pieces together. Thank you to Minister Yara Sachs for that introduction and that opening, and thank you, Delane, for getting us started. My name is Desmond Williams. I am one of the putting the pieces together steering committee members. I'm also a part of the National Advisory Committee for Pain Canada, and I'm also the co-director for the Pepper Project. Um, I'm somebody who is a speaker, somebody who does therapeutic practices such as trauma release exercises, and I'm also audio engineer and sound designer, working with some specialized 4D sound design these days, doing some experiments with pain relief and tissue healing. And today I'm coming to you from Vancouver, which is the unceded stolen territories of the Musqueam, Tsleil-Waututh, and Squamish peoples, and where I am specifically was formerly known as Kemkemlé, otherwise known as Grove of Maples, and the landscape that I see outside today definitely doesn't look like that. But I know the memory of the land lives underneath all the concrete that we have built.
Stop the interpretation of the Semianic to the
Excuse me, I just had some random voices from the background in our Zoom coming through my phone. So that is where I am. And today we are going to be discussing key developments and hearing from some leaders representing provincial pain initiatives in BC, Manitoba, and Quebec. And we are going to explore the goals of these efforts and learn what the difference between these provinces' strategies and seeing how we're going to try to make an impact on the lives of the people in these particular places. And so we're going to give a moment to introduce each one of our speakers. And so we're going to start with Christine, if you could introduce yourself.
Great. Thanks, Desmond. Good morning for those folks who are coming to us from Western Canada, and good afternoon for those who are in Central and Eastern Canada. My name is Chris Jack. I am the Executive Director for Pain Care BC. I want to tell you a little bit about Pain Care BC. We are established as a health improvement network. We were established in 2023 through a mandate from our Provincial Ministry of Health, recognizing the need to improve pain care in British Columbia. This was largely in part due to over a decade of advocacy from Pain BC, people with lived experience, and clinical pain providers in this province. We're called a health improvement network as we're tasked to better understand how pain care is delivered across BC and put forward strategic actions on how we can improve it. So Pain Care BC sits amongst 5 geographical health authorities in BC, and we all work together to collaborate on what's needed to be done to improve pain care across the continuum of healthcare. So we have 5 key objectives as part of Pain Care BC. We want to improve treatments and supports for patients who are experiencing transitional chronic pain. We want to prevent the onset of chronic pain. We want to empower people to better manage pain effectively. We want to increase the capacity of providers for pain care, and we want to improve how pain is understood in this province. So Pain Care BC acts as a provincial facilitator to inform government, to collaborate with health authority leadership, to collaborate with healthcare providers, to collaborate with advocacy agencies such as Pain BC, and most importantly, to collaborate with people with lived experience to further the momentum already created and continue to move the dial on pain care in British Columbia.
Thank you so much, Christine. Really looking forward to seeing what we have moving forward with these projects and these initiatives. So that was Christine Juck, and we are going to be moving on to someone from Quebec, Lucy. If you could introduce yourself, and this will be in French, everybody.
Oui, merci beaucoup. Thank you, Desmond. Bonjour, oui, Lucie Beauregard. Je vais débuter en me présentant. Donc, je suis conseillère au ministère de la Santé et Services sociaux, spécifiquement dans le dossier pour un continuum en douleur chronique, sous la direction des services hospitaliers, la direction générale des affaires universitaires, médicales, infirmières et pharmacologiques, et ça depuis 2019. Je suis infirmière de profession et j'ai travaillé pendant plusieurs années comme clinicienne en gestion de la douleur post-opératoire, douleur persistante au Centre universitaire de santé McGill, ainsi que coordonnatrice réseau lors de la mise en place du Centre d'expertise en gestion de la douleur chronique de l'Université de Montréal. Cette expérience dans le milieu de la douleur a consolidé les aptitudes de travail en équipe, de collaboration qui sont bien nécessaires et de bien connaître l'écosystème douleur au Québec. Donc, je vais passer la parole à Craig Desmond.
Thank you, Lucy. And again, like I'm really looking forward to seeing all of the different approaches that we're going to take in our different provinces and how we'll be able to collaborate. So our last presenter here that we're bringing to the panel is Craig. If you could give yourself an introduction.
Thanks, Desmond. So I'm Craig Hillier. I have been for just over a year now the director of the Manitoba Pain Care Program. I'm sitting at Health Sciences Centre, which is Shared Health Hospital in Manitoba. So it's the sort of tertiary site where we take care of everyone in the province. Last year, well, about 18 months ago, I suppose, we were lucky enough to receive some funding to expand and create a pain care program in Manitoba. We'll talk about in a little bit. I am the inaugural director for that work. It's been an interesting year to date. We've brought together the 5 pain clinics in the province, including the one in our far north, to try and do some standardization and to make sure that we extend our reach to everybody in the province who needs our services. Looking forward to chatting with you guys about it later.
Awesome. Thank you so much, Craig. Thank you so much, Lucy and Christine, for the introductions. And so we're going to get this panel started for everyone. We're just going to be going through some questions with each one of these individuals. We're going to get a chance to hear from each one of them for each question. And then at the end, we will have some time for Q&A. So if anyone does have questions, please utilize that Q&A function at the bottom, and we will make sure that we do our best to get through those questions in our last 15 minutes. So as we get started, the first question I have, I'm going to be posing this to Christine first, then Lucy, then Craig. What is your province doing to improve pain care for people?
Great. So in British Columbia, Pain Care BC is developing a provincial strategic direction. We're calling it a strategic action plan. And this is being developed with the engagement of people with lived experience and healthcare providers across the province to really set a blueprint or a provincial map of key areas of focused work that each health authority will then take forward for their own regional planning. So the key areas that we're focusing on within this plan, there's 5 key areas. The first one is access. We're looking at focusing on standardization access to self-management programs. We want to look at decreasing wait times for regional pain programs. We're looking at increasing the number of transitional pain clinics, and we're looking for innovative solutions to care to include working with primary care providers to better support patient navigation. The second area is around education. So we're looking towards competency standards for healthcare practitioners working in pain across different disciplines. We want to advance education for physicians around opioid prescribing, management of patients who require opioids, and interventional guidelines for pain care. The third area is around standards of care. So we are looking to develop a research network to try and translate evidence into practice. So we really want that evidence-informed care for pain. The fourth piece is on outcomes. We're looking to develop a provincial database. We want to better understand what services help which patients and gain further insight from patient-reported outcome measures. And then the last area around this strategic action planning is around prevention and promotion. So we want to participate in public education and awareness campaigns about pain care. So that's why we're here today and spreading the word. We want to bring attention to specialized populations as well, such as Indigenous populations, women's health issues, and pediatric populations' health issues as well. The other piece that we're doing to improve pain care is we've created a patient advisory group in collaboration with Pain BC to inform the work that we're embarking on. We really hope that this patient advisory group will act as a mechanism for us to check out our assumptions and ensure that what we're putting forward is going to make an impact to the patient experience. And then lastly, a big piece of work that we're doing to improve pain care is creating networks to bring people together across the province. We're creating clinical networks, we're creating operational networks, and academic networks as well. And again, we're looking at representation from across the province. We're also bringing government leads into these conversations so that we can all work together to improve pain care in British Columbia.
That's great. Thank you so much, Christine. And I just want to highlight as well how lucky we are in BC to kind of had a head start, you could say, on some of the other provinces. We've been lucky to have been working on some of these projects for quite a long time. Um, and, just wanted to acknowledge that some of the progress that we've made here in BC has been, kind of the trail has been blazed a little bit by Pain BC and with Pain Care BC as the new mechanism for this. I think, we have a lot of potential to create some really great change moving forward in our province. And hopefully, with this foundation, we can help our other provinces along if they are, needing some help as well. So thank you, Christine, for that. And I'm gonna shift over to Lucy to ask, what is it that you guys are doing over there in Quebec?
Merci beaucoup, Desmond. En fait, il y a eu publication des orientations pour un continuum en douleur chronique et la publication d'un plan d'action. Ce plan s'échelonne sur 5 ans, 2021-2026, et a été élaboré avec les collaborateurs et représentants du réseau douleur chronique au Québec, soit les patients, des chercheurs, des cliniciens, médecins spécialistes. Le plan se découle sur 5 axes, soit sur l'accessibilité, le rôle du patient, le transfert de connaissances, l'évaluation, amélioration de la qualité, ainsi que la gouvernance nécessaire pour mettre en œuvre ce plan d'action. Il y a toujours 6 principaux objectifs à ce plan. L'amélioration de la prise en charge de la personne souffrant de douleurs chroniques, et ça à tous les niveaux de soins, en favorisant une approche interprofessionnelle, biopsychosociale, et ce pour l'ensemble de la population, pédiatrique, adolescente, adulte et gériatrique. Deuxième objectif, l'amélioration des mécanismes d'accès. Donc, c'est afin de permettre justement aux patients d'accéder aux services et soins, et ce, à tous les niveaux. L'importance du rôle du patient est un troisième objectif, donc par le maintien de son autonomie et la prise de décision partagée entre le patient et le professionnel de la santé. Le quatrième grand objectif ou objectif stratégique, c'était la nécessité aussi de soutenir les cliniciens, médecins professionnels de la santé, dans les meilleures approches en gestion de la douleur et au travail en interdisciplinarité. Et ce, par des activités de formation, mentorat, consultation. Cinquième objectif, l'instauration d'une culture de l'amélioration continue, la pratique réflexive, donc au niveau de la pratique clinique et organisationnelle en gestion de la douleur chronique, et ce, ancré sur les besoins des patients, et la mise en place d'une gouvernance clinique, comme je l'ai mentionné, et organisationnelle, incluant la participation du patient à tous les niveaux du réseau de la santé et services sociaux. Et cette gouvernance est afin d'assurer le suivi du plan stratégique. De ces objectifs ont découlé des projets, des activités, des chantiers de mise en œuvre. Il y a eu, je vais vous en nommer quelques-uns. OK. Il y a eu un travail afin d'harmoniser les critères de priorisation et d'accessibilité aux cliniques de douleur au Québec. Il y a actuellement 28 cliniques de douleur désignées dans le réseau public au Québec. Donc, il y a eu un travail pour tenter d'harmoniser les critères et il y a eu révision du formulaire de référence qui devrait être implanté au cours des prochains mois. Deuxième projet, élaboration d'un projet de mise en place d'équipes interprofessionnelles dans les services de proximité, ce qu'on appelle la première ligne, donc dans les cliniques médicales, familiales, dans les CLSC, en équipe, en soutien et avec les médecins de famille. Donc, pour améliorer la prise en charge dans les services de proximité, pour accueillir les patients, qu'il y ait une évaluation de leur situation clinique et s'assurer d'une prise en charge, d'un accompagnement dans le réseau lorsque nécessaire. Il y a aussi un soutien qui était apporté au développement de la plateforme de formation pour les professionnels et pour les patients. Certains d'entre vous l'ont probablement utilisé. Cela inclut un programme d'autogestion autoportant, Gérer ma douleur. Et aussi, il y a le développement sur l'environnement numérique d'apprentissage, ce qui est une plateforme provinciale de formation continue. Donc, le soutien a été accordé. Il y a poursuite des travaux de développement et en cours de déploiement de 2 projets informatiques en télésanté, consultation virtuelle pour des échanges interprofessionnels et aussi la communication asynchrone sécurisée et structurée entre le professionnel et le patient. C'est à suivre. On est en projet pilote à ce moment-ci. Et il y a aussi le suivi virtuel en milieu de vie qui consiste à l'enseignement, le suivi personnalisé à distance afin de soutenir les patients dans la gestion de leurs symptômes et dans la prévention des aggravations. Autre élément important en soutien ou dans la mise en œuvre du plan d'action, il y avait déjà des activités éco, éco-douleur CHUM. ECO signifie, c'est l'acronyme de Extension of Community Health Outcomes. Certains d'entre vous connaissez peut-être les sessions ECO de d'autres domaines de la santé, mais nous avons la chance d'avoir cette activité-là, éco-douleur CHUM, et le développement de ECO-CUSM en anglais, pour la population anglophone au Québec. C'est un réseau d'échange et de transfert de connaissances entre professionnels dirigé par un groupe d'experts. Ça devient comme une communauté virtuelle composée d'équipes cliniques. Dernier élément important, nouveau, qui est venu avec le plan d'action aussi, c'est la mise en place de répondants douleurs chroniques dans chacun des établissements de santé et l'élaboration de plans d'action dans chacun des établissements. Donc, ce plan, l'adoption a permis de sensibiliser les parties prenantes et de mobiliser les différents partenaires et collaborateurs du réseau œuvrant auprès des patients atteints de douleurs chroniques. Merci.
Awesome. Thank you, Lucy. It really sounds like you guys are creating a very large team so that everyone can work together to really bring this forward on so many different levels, including, you know, having the patients be so involved and included. So yeah, it's really great to hear. And you know, just saying what I said the other day in our meeting, it is great to have some French speaking here in the conference because it really, I think, expands our reach, our accessibility, and you know, our intention of being able to find all of the different unique communities throughout Canada. So thank you so much, Lucy, for sharing that. And lastly, we'll move on to Craig. And you know, I'm curious to hear what you have as you know, we are just in the early stages of your guys' collaborations.
Yeah, thanks again, Desmond. So I feel like, you know, despite the fact that pain care clinics have been in operation in Manitoba for many, many years, this new journey that we started on last year is a little bit different. I feel like I'm a newbie to the group compared to my colleagues. During the course of the pandemic, there was a real realization that, amongst other things, of course, other services, pain care was difficult to get to. There was a lot of people waiting, and they had to wait for quite a long time. So, coming out of the pandemic, there was a proposal written to address the services offered to those living with chronic pain in our province. It's when you think about it on a year-over-year sort of basis, it sounds like not very much, but really over the course of the next 10 years, we've been given $40 million by our provincial government, so kudos to the government for their foresight, to change and increase access to pain services in Manitoba. So really what we're trying to do is take our current model, our previous model, I suppose, and flip it around a little bit. So the traditional model of receiving care in most specialties has been, through the physician, and then a plethora of options open up to you after that initial visit. However, we do know that there are very important parts of chronic pain care that are provided by other providers. So we're trying to flip the funnel around a little bit and bring in a team of providers. We have hired a group of physiotherapists, occupational therapists, psychologists, to start to see patients earlier in their journey with a goal of having them being in contact with a provider of some sort within the national benchmark of about 6 months. We've managed so far to decrease that wait time to initial contact from about 40 months at one point in time to somewhere around 14 to 16 months, depending on which clinic. Some are a little longer, some are a little shorter. The other thing that we've really tried to do in Manitoba is connect all of the service provincially. So we designed a hub and spoke model where HSC, which is Manitoba's hospital, being the hub, providing some services to support the care that's provided in other clinics, and the other 4 clinics being the spokes. As a side note, we did have only 3 clinics up until last year, so we managed to open an additional clinic in Selkirk, Manitoba, which is just north of the city. And it's been really great that's helped us decant some of those patients that were north of the city, but come into Health Sciences Center or Pan Am within the city for care. So we're excited to be able to do that. We really want to have patients receive holistic care, meaningful care. And meaningful care means having a team of interprofessionals around that patient and providing all of those wraparound services that people need. And we're working towards that. We still have some vacancy that we'll talk about in the next section probably, but we're really working hard to get those patients who come onto our wait list into a group of providers so that they can receive education, they can receive counseling if that's what they need, they can identify what are their goals of care from our pain clinics and move forward together with the medical, visit being closer to the end of the journey and providing that type of care too, but really making sure that they have all of the care providers around them that they need to have a successful pain journey and meet their outcome desires as a patient.
Awesome. Thank you so much, Craig. And I really appreciate all 3 of you. How, the approach seems to be that we are really starting to look at a multidisciplinary approach to pain, as opposed to, trying to find one singular answer, which many of us who live with pain have realized over the years. There isn't one singular answer often to managing our pain. And so being able to be set up and connected with a multidisciplinary team can really mean so much. And I also just wanted to highlight something that Lucy had mentioned about the follow-up, the 10-year, and with that connection, that continued connection, I think that's a really great thing, that maybe myself, I would have appreciated through my many years of managing my pain is having something that's actually scheduled as a follow-up to talk about, how I'm doing. So thank you all for sharing, all those pieces of what we're working on and what we're doing to improve pain in these provinces, and recognizing that there is work being done in all of the rest of the provinces as well, on different projects, but we just, we don't have time and space for all of the provinces today. We're happy to highlight these ones here. And so as we move on to our next question for you guys, we're going to be going in the same order. And the question is, what barriers to improving pain care in your provinces do you find there are?
So So in British Columbia, we have lots of variation in how services are being delivered. We have a vast geography, and as I mentioned before, we have 5 geographical health authorities who are all run by their own, independent leadership. And it's a big piece that we're looking at trying to improve is around some standardization, because there's really a lack of standardization of pain care in our province. We know there's high wait times for many of our services, and there's no clear navigation path to access the right services at the right time by the right provider. Resource allocation, it's great, Craig, you're talking about the resource allocation in Manitoba. We know across our health authorities in British Columbia that this is very different across the board. And it's been fairly limited for many of the health authorities. And it hasn't always been put forward as a priority within the health authorities. So that is a barrier for us that we're really trying to improve and trying to push forward with. Also a lack of formal structure within the health authorities to coordinate and advance pain care has really resulted in a lot of silos, even from within the health authorities themselves, even within each health authority. So that's another area that we're really trying to push the dial and trying to improve and trying to look to the health authorities to create more collaboration within their own infrastructure. The other piece that I mentioned earlier is around the unique leadership structure. Each health authority has their own leadership. So we're trying to determine how to advance the work with this variability and how to ensure that pain care is put on the radar for these leadership tables and for decision makers so that we can create more momentum and move forward in these areas of improvement for pain care in BC.
Thank you so much, Christine. And so I will shift over to Lucy with the same question. What are some barriers that you're finding? And just, yeah, there you go.
Thank you. Thank you, Desmond. Merci. Et oui, il y a des barrières. Les principales barrières, en fait, pour améliorer la gestion de la douleur pour les soins de douleurs chroniques portent sur la disponibilité et l'accessibilité à des ressources, tant humaines, matérielles, informationnelles et financières. Fort probablement que ce sont les éléments, les ressources nécessaires. Ce qu'on retrouve, il y a 5 éléments que je veux partager avec vous aujourd'hui. La disponibilité des ressources professionnelles et médicales à tous les niveaux de soins. Je ne crois pas que nous soyons la seule province avec cette problématique. Donc, afin de maintenir une offre de services compétente ainsi qu'une offre de formation, d'enseignement et de mentorat en gestion de la douleur chronique auprès des cliniciens. Au niveau de l'accessibilité ou la disponibilité des ressources humaines dans nos milieux de soins, donc bien que des améliorations aient été apportées, l'accessibilité aux services demeure un enjeu des services des soins. Dans le réseau public, tout particulièrement, l'accès aux services de réadaptation et psychosociaux, tant dans les services de première ligne que dans les services spécialisés, n'est pas optimal. On retrouve ces services-là du volet, parfois dans le réseau privé, mais ce n'est pas tous les patients qui peuvent avoir le privilège d'accéder à ces services privés. Donc, au niveau du réseau public, des efforts doivent être apportés. Il y a une reconnaissance du besoin, il y a d'une pratique interprofessionnelle, il y a des travaux qui sont en cours, il y a des orientations qui ont été rédigées aussi à cet égard, qui sont publiques, mais les besoins demeurent. Donc, on va poursuivre le travail à ce niveau-là. Une autre barrière, c'est qu'on le sait, nos réseaux de santé sont complexes. Le parcours discontinu pour le patient, c'est-à-dire un parcours entrecoupé qui n'est pas fluide pour le patient et ses aidants dans le réseau demeure un enjeu. Il y a peu de mécanismes de navigation d'une installation à l'autre ou d'un service à l'autre, tant dans les services de proximité, les services spécialisés. Ou que ce soit au niveau de la transition d'un service à l'autre. Il n'y a pas ou peu d'accompagnement non plus pour le patient et ses aidants pour naviguer ou aider à naviguer dans le réseau. Donc, c'est quelque chose aussi sur lequel il y a vraiment une volonté de travailler. La communication des services spécialisés vers les services de proximité entre les installations, les différents services de soins de santé, bien, doit être améliorée. Ça aussi, c'est quelque chose il y a toujours place à l'amélioration.
Mm.
Et un des enjeux, une des barrières au Québec, l'absence de données cliniques, l'absence de données cliniques standardisées et partageables en lien avec la prise en charge de la douleur pour le patient, bien, c'est un enjeu. On ne sait pas par qui le patient a été vu, quand, pour quelles raisons, en lien avec la douleur. Si la demande de consultation vers une clinique spécialisée en service spécialisé a été transmise dans plusieurs sites, sur plusieurs listes d'attente, ce sont des éléments sur lesquels certains projets ou chantiers ont été démarrés, mais ça demeure encore une barrière à ce moment-ci. Il y a du travail de concertation à accomplir pour arriver à mitiger ces barrières. Merci.
Merci, Lucy. Yeah, and those are some unique challenges there for your
Yeah.
province, with the privatization and some other things that are, that secondary obstacle to accessibility. So, the fact that we have it highlighted and we're creating some strategies to
Mhm.
find some solutions for that is very heartening. So thank you, Lucy. And we'll move on to Craig for the last answer for this one. What barriers do you find in these early stages of creating these things for your province?
Yeah, so I started out by saying we're at different places in our journey, but I will say I do hear some similarities when we get into this section for sure. I think one of the things we're running into is just our ability to successfully hire and maintain our complement of staff. So we've had some changes there. And really, if anyone who's listening knows a psychologist that's interested in moving to Manitoba, I have a great job with a great team for you. Um, so that's one of the things. I think the expectations of the patients who are waiting. So we're in the middle of this big change of process and big change of philosophy. And if you've been waiting for 2 years to see a pain specialist, you often don't want to have a phone call to say, hey, we have an appointment now for an occupational therapist or a physiotherapist. You've been waiting for a physician. So the throes of the change with the numbers of people that have waited have presented some challenges that we're working through. I think we're close to resolving some of how we do business in our new model and switch out from what we were doing before to what we're trying to do now. I think one of the things that I heard Chris mention was geography. So we have 5 pain clinics that are stretched out across all of Manitoba. And for an area in Toronto or Ottawa or Montreal or major hubs to service 1 million people or 1.5 million people, the geography where those people live could be very small. We service about the same number of people, but we draw from the Northwest Territories and Northern Manitoba, a little bit from Saskatchewan, depending on where you live, if you're close to the border, a little bit from Northwestern Ontario, and it's a vast, vast area. So from the hub clinic here at HSC to our furthest reaching clinic is about 800 kilometers by road. So it's a long drive. It's also very far north. So trying to provide the same services that we can, equitably across the system is a challenge. I lived in the north for 2.5 years and I loved living in the north. I actually miss being in northern Manitoba some days quite a bit, but living in the north is not for everyone. So attracting those professionals can be a challenge for sure. The other piece is providing those services electronically, like we're doing right now. It works for some places in the north, but there are lots of places that don't have easy access to cell service or satellite-based internet where, a really stormy day makes it very difficult to do business that way. So we have to figure out how to do a little bit better job of that. And I think really trying to service everybody in a fair, equitable, and really high quality way has been one of our challenges, in particular when you're far removed. So we're really thinking about how to do that well.
Awesome. Thank you, Craig. And, I think as we continue to move forward collectively in, boosting the awareness and the voice of people with pain, the more that our governments and everything become aware of it, that we'll get more support and we'll be able to draw these connections and create a tighter network within all of our provinces and together. So. Thank you guys for sharing that part. And we have got a couple more questions for each of you. Um, and so the next one I have for Christine. What are you most hopeful about as you undertake this work?
Thanks, Desmond. I thought a lot about this question, and I really feel like with the past work that was done in BC and this future work that we're embarking on, that we are positioning ourselves to better inform leaders and decision makers in the province to understand how pain care impacts the overall healthcare system. And that by investing in pain care and increasing their investments in pain care, there'll be benefits to areas like, overcrowded emergency departments. We can impact those. We can impact hospitals who are over capacity. And there'll be communities full of patients who are able to manage their pain more effectively. Again, like I said before, I really am hopeful that patients will be seen at the right time by the right provider. And, I'm hopeful that there'll be different parts of the system that will be more connected, all the way from primary care, all the way to, your higher level of tertiary care. And I really believe that navigation right now in our healthcare system is really complex, but I'm hopeful that it will be simplified, and I'm hopeful that we can, put forward some paths to simplify that navigation for patients. I'm also hopeful that more practitioners will understand and validate pain care in their practices, and that patients will be heard, they'll be supported, and they'll be provided the care and the management that they require.
Awesome. Thank you, Christine. And moving over to you, Lucy. What is it you're most hopeful about?
Yeah, c'est une question pour laquelle j'ai dû moi aussi m'arrêter et bien réfléchir au type de réponse à apporter. Écoutez, le travail qui a été entrepris au cours des dernières années, c'est un travail de mise en œuvre, de gestion de changement et de coordination des forces présentes dans le réseau de la santé au Québec. Donc, pour poursuivre les travaux, pour améliorer l'accessibilité, assurer une offre de services pertinente aux patients, pour le patient, on doit s'assurer de maintenir ou instiller la motivation auprès des équipes, les solliciter pour trouver des pistes de solutions à l'accessibilité en faisant preuve d'innovation, demeurant informé, formé, en adoptant une pratique clinique basée sur les données probantes. Et progressivement, ça s'instaure comme culture de milieu, en tout cas, je l'espère. En tout cas, c'est ce qu'on voit dans nos travaux. Il y a aussi près d'une quinzaine d'années, le ministère, en collaboration avec un groupe d'experts, ont proposé une gouvernance par réseau universitaire pour assurer la mise en place d'orientations, les premières, dans l'organisation des soins et services. Et cette gouvernance inclut différents acteurs du réseau de la santé. Il y a chercheurs, professeurs, cliniciens, patients, représentants des ordres professionnels, différentes directions du ministère de la Santé, les représentations des centres d'expertise. Cette gouvernance est maintenue et puis a été maintenue avec le nouveau plan d'action et ses collaborateurs ont une responsabilité dans la mise en œuvre du plan d'action. Puis au cours des années, il est évident que cette gouvernance-là a permis de miser sur les forces de chacune des instances du réseau de la santé, que c'était une valeur ajoutée. Donc, d'avoir des objectifs, c'est une chose, mais il faut s'assurer qu'on travaille dans la même direction en collaboration. On doit se rappeler le pouvoir de la communication, collaboration, complémentarité. Donc, exprimer les possibilités puis les limites respectives de chacune des instances, de s'entendre sur notre carré de sable dans lequel on peut travailler ensemble vers un objectif, puis identifier les opportunités d'amélioration. L'autre élément d'espoir, ce que l'expérience nous démontre, c'est bien qu'un professionnel puisse faire une grande différence auprès d'une personne qui souffre. L'amélioration des soins et des services en gestion de la douleur chronique n'est pas l'apanage d'une seule personne, d'une seule instance. On doit travailler ensemble avec et pour les patients dans une vision partagée, commune. Merci.
Thank you, Lucy. Yes, it really is nice to see that despite the speed of some things moving forward, that we are seeing some significant change. And so, Craig, the last one for this question. What are you most hopeful about as you undertake this work?
So for me, when I saw the list of questions, I think this was the easiest one for me to answer. But I'm gonna start with a short story about two of my kids. So I have a 9 and a 10-year-old. My 9-year-old was struggling to accomplish a task, was getting super frustrated. And my 10-year-old looked at him and said, just remember what they told us in school. When you fail, that's your first attempt in learning. And so what really makes me hopeful here is I'm surrounded by a team of people, big teams of people who are very good at being successful, but are also willing to try and fail and learn and shift gears. So we have a huge group of people, no matter what we take on. It's like if that's not working, there is a fantastic idea to adjust it and make it work for patients, make it work for clinics, get good care out to people. So I think the thing that really makes me most hopeful is that team of interprofessional people who really will not stop until we're successful in providing top quality care to each and every patient that asks for our services and needs our services.
Awesome. Right on. Okay, so we are at 11:02. We are going to have some questions that we're going to get to, but I have one more question for each of you guys. And with this, because we are running a little bit short on time, I would say if we have like one example, maybe two for this next question, just so we can get to the Q&A. And so for our last question, what role do you think people who live with pain could play in improving pain care in your province? So we'll start with Christine.
Great. So I'll be quick, but I have 3 areas. One is helping set the direction. So help informing the plan and informing us where research and training needs to go and helping us check out our assumptions on what's happening in pain care. That is definitely a role that people who live with pain could help with us. The second piece is spreading the goals of where we want to go in terms of our action planning, spreading them in their own areas with decision makers, with their own health authorities, trying to advance these local services and trying to, be on the same page as everyone in the province and kind of pushing their decision makers on that. And then thirdly, is partnering with us to provide insight in how to provide better care, what it means when care is delayed, advising us on where the current gaps are and where we might need to eliminate these gaps or barriers and ideas around that.
Awesome. Thanks, Christine. And so everybody watching, Pain Care BC and Pain BC, search them out and see how you can connect with them, those of us in BC. And so moving over to Lucy, what role do you think people with pain could contribute?
The role of the patient is very important when in relation to sorry, I'll go back in French.
Okay.
You're asking, vous posez la question en anglais, je réponds en anglais, je suis désolée. Alors, au niveau du rôle du patient, c'est l'un des 5 piliers dans le plan d'action provincial et on souligne des objectifs spécifiques puis des actions pour s'assurer du rôle actif du patient dans sa prise en charge. Donc, premièrement, son implication dans le processus décisionnel avec le professionnel de la santé et le médecin. Donc, ça, c'est un des éléments très importants de sensibilisation, d'enseignement, de poursuivre la démarche là, avec son professionnel ou son médecin. Et de prendre un rôle proactif dans son traitement, c'est le patient comme individu. Au niveau, au niveau provincial, on ne peut pas renier la force du groupe. Quand, face à cette question-là, ce que je réalisais, c'est qu'au cours des dernières années, l'Association québécoise de la douleur chronique au Québec, elle représente les patients souffrant de douleurs chroniques, puis ils ont participé activement à l'élaboration du plan d'action dont je vous ai parlé, mais aussi ils assurent le suivi de la mise en œuvre du plan. Ils assurent une cohérence avec les réalités terrain pour les patients. Ils sont présents dans le processus de mise en œuvre du plan d'action et donc s'il y a un nouveau contexte, bien on est au diapason. On veut les entendre. Donc, c'est important aussi la force des groupes, des regroupements. Particulièrement aussi, ce regroupement a œuvré à déployer, maintenir des groupes d'entraide pour les personnes avec de la douleur chronique, avec de la douleur persistante. Il y a différents regroupements de patients, mais ces regroupements assurent une représentativité. Ils favorisent le partage des expériences personnelles et nous permettent, sont nécessaires pour contribuer à l'amélioration des soins et des services en douleur chronique. Donc, c'est au niveau de la force des patients, de leur implication, c'est très important et c'est ça. Merci.
Yeah, it seems pretty much the work doesn't move forward without the patients, correct?
Ah,
It's not going to happen without them. And
Mhm.
so, again, over our friends in Quebec, that's our call to connect. And so, moving on to our last one here, Craig, what role do you think your patients could play? Maybe similar?
Well, I suppose I could just say ditto and kind of be done with it there, but I think really we do want to hear from you. I want to hear from you. The pain clinic in your community wants to hear from you. What we're doing well, what we need to do better. One of the things that I would love personally to hear from all of our patients is what is your measure of success? At what point in your pain journey have we been successful in improving your day-to-day life, your ability to function at home or in the workplace or whatever the issue was that brought you to us? We can define success together. Our success really is your success. So I think we really need to hear that. Other than that, I think what I would say is continuing to talk to your MLA, your physician, the health authorities, whoever will listen, other patients about your pain care journey and what it means to receive good pain care would be really helpful for us as well.
Awesome. Thank you, Craig. Um, And so, again, it really is just a call for action here for all of us in attendance. These projects really are created with the intention of having us be involved as people with lived experience, and the work doesn't move forward without us. And so, if you feel inspired, you feel compelled, please find a way to reach out. So we have just a few minutes here for our Q&A, and we do have a number of questions in our Q&A. And so apologies to those whose questions might not get answered in this moment. It's possible we may be able to do some follow-up as well. But in the meantime, I'm just going to go through a couple of these questions here. And so I have one specifically for Christine, um, and this is kind of a compilation of two two questions here that are relating to similar things. And really, it's about for people who have been dealing with pain and have been referred to interventional pain clinics, but have these long wait times, looking at a year and a half wait list and stuff like that. Is there anything do you that you're aware of that's being done to increase the capacity of these pain clinics so that maybe we can get some of these wait times down?
Yeah, great question. We're really trying, through our networks and our collaboration with all of these pain clinics, we're really trying to better understand the patient journey and looking at, okay, what can be done while patients are waiting for services. So we're also looking at some new models of care that involve more of kind of a single entry model where we can actually, provide some additional support, whether it's self-management program support or other support while people wait. And then also, really look at ensuring that patients that are waiting for the right service. And that's how it kind of goes back to the, right service by the right provider at the right time. The other thing that we're really trying to look at is increasing capacity of healthcare professionals. So we're looking at how do we get pain care curriculum and education into the university programs earlier on. How do healthcare practitioners, get this information around being a pain care specialist earlier in their professional careers? And, how do we look to, promote more allied health professionals, more physicians working as pain specialists? So that definitely is an area that we're focused on in BC for sure.
Okay, thank you. And I hope for the few people in the chat who we're looking to have a question along those lines answered. That is something that maybe offer a little bit of hope moving forward. As we're all very aware of how difficult it can be with those wait times, as were highlighted by all three of our provinces present today. It seems that there's a lot of people with pain, and we're just trying to catch up on the institutional level about addressing that. But we recognize that it's very difficult in the meantime while you're dealing with it to not really know what's going on. So thank you for that, Christine. I have another question here as we have a few more minutes. And I'll pose this to all three of you if anyone feels compelled to answer. And so this particular question, when it comes to the many different things, the different components of helping people deal with pain, are there any of you who are involved with anything or aware of anything specifically that are using the considerations with your interventions that are addressing the social determinants of health, such as poverty or disability among the academic initiatives?
I can just speak to some work that we're doing right now in BC. So, we work closely with Pain BC, and I know a lot of their programs and initiatives are looking to address many of the social determinants of health. The other thing that we're trying to do a bit of or get a better understanding on is our community health centers. And a lot of our community health centers actually focus on support for vulnerable populations or marginalized populations. And we're really trying to understand potential partnership or role that we might have with these community health centers, which really are addressing a lot of the social determinants of health and how we might partner with them to help address these for patients who are living with pain.
Thanks. And anybody else have anything they'd like to offer to that?
So I would say, Desmond, it is a really important consideration, but in the context of where we live in the health system, one that's really hard to address. Chris
Right.
had mentioned Pain BC. Pain BC does have a program called Making Sense of Pain that addresses some of those social determinants of health issues. Not all of them, but it's super helpful. So in
And
Manitoba,
it's growing.
we're looking at how we can offer a program like that in Manitoba in partnership with Pain BC. There are programs all across the country right now. There's not one in Manitoba yet. And looking at, can we partner with, again, our community organizations out there where the people are that need the services. Health Sciences Center in particular is difficult to get to. There's a lot of traffic. Parking is a nightmare. What if we brought something to them closer to where they live, the people that need those services? So I think that there's an option there for us to do some of that work or to help get through some of those barriers.
Awesome. Thank you, Craig. And just as a person who's involved with some of that stuff as well, to answer that question, there are some projects happening right now that are in the research aspect of how we can implement equity, diversity, and inclusion into the research aspect of doing pain research. And so for those who are interested, there's something called the Pepper Project, the Partnership for the Engagement of People in Pain Research, which I'm the co-director of that project. There's also the Equitable People Health Management Project that's happening with Trinity Western University right now, which has been going on for a couple of years, where they are looking to tailor research based on your answers to specific questions to make sure that they are incorporating your social determinants in the results of your questionnaires. And we are working towards finding the best way to approach that currently. And so, unfortunately, that is the end of our time for our Q&A. Apologies to those who didn't get a chance to have your answers or your questions answered, as we had a lot of very rich material today and a lot to share. And so thank you so much to Christine, Lucy, and Craig for joining us for our first session in this Putting the Pieces Together conference. And, it's really a beautiful thing to see all of the different provinces working on their own projects, but, with all of these things keeping us connected and together so that we can move forward together. So appreciate you all for taking the time and for all the work that you do. And I'm going to hand it back to Delane to move into our next portion of the day.
Desmond, and yes, thank you, Christine, Lucy, and Craig. The information that you presented throughout was so valuable, and I know there were lots of really great questions in the Q&A. So next, I just wanted to remind everybody that this session will be recorded, so you can rewatch it later. And next, what we're going to do is we're going to take a short 15-minute break. And so we'll be returning at 11:30 Pacific time and then 2:30 Eastern time. And our next session is a 30-minute gentle pain care yoga session. So please return in 15 minutes to participate for that. Looking forward to seeing you all soon.